Hello everyone, I am Dr. Ramyajit Lahiri, Consultant and Head Emergency Medicine Department, Narayana Superspeciality Hospital, Howrah, West Bengal. And with me today we have
Dr. Arindam Ghosh. I am a consultant neurologist at Narayana Superspeciality Hospital at Howrah and in charge of the stroke unit.
So today we came here actually to discuss about stroke. So Dr. Ghosh, being a neurologist, how often do you see stroke patients?
Stroke is possibly the commonest neurological emergency, Dr. Lahiri. Several people worldwide have been afflicted with stroke. Greater the age, greater the propensity for developing stroke. We know diabetes is on the rise, hypertension is on the rise, dyslipidemia or abnormalities in cholesterol levels are on the rise. We have sedentary lifestyles as compared to our predecessors, and over time, stroke is becoming an epidemic across the globe, particularly in our country. So it's a very, very common neurological problem. In fact, it is the commonest neurological emergency that we deal with.
Okay, great. What are the signs and symptoms? Maybe anyone. I'm talking about a normal person should look for to identify.
That's a very nice question. We must know that stroke is technically a neurological disease which is caused by the cessation of blood flow to the brain. So blood flow to the brain is interrupted. The normal oxygen that is provided by the blood flow to the brain is interrupted. Therefore, when the brain cells are deprived of this oxygen, they begin to die. And those functions that are served by the particular area of the brain that is damaged will begin to be impaired, or if not prevented, if not stopped at that stage, lost forever. That is why prevention of stroke, early recognition of stroke and treatment of stroke is of utmost importance to prevent disability and loss of life sometimes. The most important symptoms of stroke that any layperson, any person who is listening to us today should know of is or can be remembered by a very simple mnemonic called BEFAST, B-E-F-A-S-T. B stands for balancing problems, where a person feels disbalanced or unbalanced, becomes unsteady while walking or standing. E stands for eye problems, so you may have visual loss in one eye, or on one side of the field of vision you have abnormalities you can't see. The third symptom is F, facial deviation. F stands for facial deviation. A, the next is A, stands for arm weakness, also leg weakness, or numbness, or a feeling of heaviness on one side of the body. So arm or leg weakness or numbness. S stands for speech-related problems. So somebody may lose his or her speech completely, may not be able to comprehend whatever is being said to that person, or may have a slurred speech. So speech-related problems. And then comes T, T for time. Time is of utmost essence. This year's World Stroke Day's motto is minutes saves lives. So every minute that is lost, several million neurons in the brain or brain cells begin to die. Approximately 1.9 million neurons are lost every minute that a person with stroke is not attended to. So quickly again, BEFAST, B for balancing problems like unsteadiness, E for eye problems like visual loss or blurring of vision, F for facial deviation, A for arm or leg weakness or heaviness or numbness, S for speech-related problems like loss of speech or slurred speech very commonly, and T, most importantly, for time. Remember, time is of absolute utmost importance. Get that patient to, if you notice any of these symptoms in a loved one or a friend, get that patient over to the emergency department of a stroke-ready center nearest to your home and get the person treated.
Precisely what you said. See, just one more point I want to make, that stroke can be of two types.
Yes.
It's mainly, it can be a hemorrhagic or it can be a
ischemic stroke. Absolutely, you're right. Ischemic stroke technically is a clot in the brain which prevents blood circulation. A hemorrhage is a rupture of a blood vessel and most commonly occurs after elevated blood pressure or uncontrolled blood pressure. Sometimes it will occur after a trauma. Sometimes that can happen if there is a small outpouching called an aneurysm that ruptures. So you're going to have various types of hemorrhages. The commoner variety of stroke is ischemic stroke, where there is a clot in the brain which occludes blood flow. And you would have, I'm sure, dealt with several of these patients in the emergency department yourself over the last several years that you've been in charge of the department. How often do you see stroke patients in your emergency?
Yes, honestly, we see quite a lot of stroke patients, and this stroke patient, basically they are treatable, very much treatable. And now we have drugs available where we can actually hydrolyze those clots, can be
thrombolized.
Yes, can be thrombolized. Yes, it's same like cardiac thrombolysis.
Yes.
Now the stroke thrombolysis is there.
It's very common.
So we have those things are available, and it is almost available in every stroke ready center. So it's always better, as you have emphasized already, that time is the main essence, and with time is bread, time is life, as the your stroke day suggests. That it is the within the time span. If patients are reaching within the time span, especially a 4.5 hours, then definitely it is treatable very much.
That time frame is so important, as you rightly mentioned, 4.5 hours. The faster you reach the hospital, as I was just mentioning, the better is the outcome. If you can administer that clot dissolving medicine, which you just rightly put across, thrombolysis, by medicines which dissolve those clots, if brought within the first 4.5 hours or the golden period, the outcome is likely to be better. Earlier you bring to the hospital, better is the outcome.
Exactly.
You have been doing thrombolysis in your center for quite a few months now.
Yes.
We are a stroke ready center in our unit.
And proudly say we are the second highest
number across the city.
Across the city. Yeah.
So, what do you, as an emergency consultant in charge of the department with your team, do when you see a stroke patient coming into your department?
Well, whenever we see any patients presenting with symptoms of stroke, well, the international guidelines say that the doctor should attend that patient within 10 minutes. But I tell you, consistently it is happening way below that time frame
in our
institute, in my department. And then we go ahead with an international guideline and we follow NIH's criteria. If the patient fulfills those criteria, below 25 minutes for the city time, and then if that city suggests that it is a ischemic stroke, then we go ahead with a thrombolysis, and the drugs are available.
Yes.
Well, we have tenecteplase, we have alteplase, it's all available. So accordingly we can go ahead. Well, there are few contraindications that we go ahead with the checklist, and when the checklist is fulfilled, then we can go ahead with on that.
So to summarize what you do in the emergency department, a patient who is suspected to have symptoms of stroke, as I was mentioning, be fast, the mnemonic little while earlier, balancing, eye problems, facial deviation, arm or leg weakness, and a speech abnormality, is brought to the emergency department. You or one of your team members assesses the patient consistently below 10 minutes, which is the international guidelines, following which you fill up the NIHS score, which is the internationally rated score to assess a patient with stroke. Then you take the patient for a CT scan, and if there is no evidence of the other variety of stroke, that is a hemorrhage, if there is suggestions that it's an ischemic stroke, in conjunction with the neurologist, you administer medicines to dissolve the clot, which is what we call thrombolysis, tenecteplase or alteplase, whichever drug we can get, and has to be within the first 4.5 hours. And of course, if the patient does not have any contraindication towards thrombolysis, if there are no contraindications to doing the procedure, administering the medicine which dissolves the clot within the first 4.5 hours.
Yeah, and actually to highlight that we are getting very good results.
Yes.
Actually, we are getting very good results. But the problem is the awareness among the society is very
has to increase. Absolutely.
Yes,
Dr.
that
Lahiri.
needs to be
Very, very important point. We tend to wait. Let's see if the patient gets better. The patient is having vertiginous symptoms, vertigo or dizziness or balancing problems or eye problems, or there's a mild facial deviation. We're not quick enough to recognize those symptoms. We wait for a day or two and then bring the patient to the emergency or to the hospital.
Exactly.
By that time, the chance to give that particular medicine to dissolve the clot is lost.
Yes.
And the disability is permanent or at least significant. So the best thing to do, identify it quickly,
Yes.
bring them to the hospital, bring them to the stroke ready center and administer medicine if possible.
Anything, any kind of doubt if you have that this patient might have a stroke, do not delay, bring early to an emergency medicine department, let the doctor check whether it is stroke or not. That way we can actually decrease,
Save lives and decrease the morbidity associated with stroke.
Yes.
Absolutely.
Yes. So, Dr. Ghosh, so how do you approach those patients after we thrombolyze?
Okay. There are certain very important things that we must try and avoid. As neurologists, there are medicines that are to be given lifelong after a person has a stroke. I'm talking about an ischemic stroke. Those medicines are typically started 24 hours after thrombolysis is done, if we can thrombolyze the patient. We follow it also with a neuroimaging study, preferably an MRI scan, if that's not possible, a CT scan, to look for the chance that there could be a small bleed because of the result of the medicine. Because we are thrombolyzing, we're dissolving the clot, there can be something called a reperfusion bleed in about 5 to 6% of patients who are administered the thrombolytic drug. So out of 20 patients who are administered the thrombolytic drug, 1 will probably have a minor bleed, which may require special types of intervention. But very importantly, we have to also assess why the patient had a stroke. Was it because of an abnormality of an artery in the brain? Was it because the clot was formed elsewhere and then propagated to the brain via circulation? Very often we have a heart-related problem that then forms a clot in the heart, and then that reaches the brain and causes a stroke. So we must be able to distinguish between a thrombotic stroke in the brain, which is a clot formation in the brain itself, versus an embolic cause for stroke, where the clot formation was elsewhere and then propagated to the brain that resulted in stroke. The ultimate outcome is the same. There is a block in the artery, but following discharge from the hospital, the medicines will depend, the type of medicines will depend on the type of etiology or the cause for the stroke.
Yes, actually I do agree with you, because unless and until you are finding out the root cause, then you cannot actually cure it.
Yes, yes.
So it is very important to find out the exact cause.
A good many patients with stroke who have had stroke once will have the propensity to have a stroke again. And unless we know why the patient has had a stroke, you are not doing justice to the patient. So depending on the type of stroke the patient has had and the various investigations that are carried out to figure out why the patient has had a stroke, we will decide on the type of medicines that the patient has to be put on, and these are always or most likely put on lifelong. Dr. Lahiri, there is sometimes this doubt that if a patient comes in a unconscious or very drowsy state, and we have felt as neurologists or as emergency physicians that you need to intubate the patient and place the patient on mechanical ventilation. Very often the cause of it could be due to stroke itself. There is this common perception in the general public that if you intubate and ventilate a patient, there is no way back from that situation. You and I both know that's not the case. How often do you face these queries and how do you address them?
Yeah, you have raised a very good question. Actually, the thing is, this is regarding ventilation. There is a stigma in the society. Few people, they think that ventilation, if a patient has gone for ventilation, that means he or she is never coming back. Another point is, with this ventilation, we are keeping the patient alive, and with this, patient is being dragged. No, it's never like that. Actually, the COVID scenario has changed this concept, partly for many people. See, with ventilation, what we are actually doing, we are inserting an endotracheal tube into the trachea and we are putting oxygen to the lung. It is nothing but putting oxygen to the lung from another source. This way, we are actually reducing the work of the lung. Now, what happens to the stroke patient is, we have a scale which is called Glasgow Coma Scale. Now, this, as per this Glasgow Coma Scale, if a patient is below 8 or 8, then we have to go ahead with intubation and ventilation. Basically, this is not to prolong their life, it is to protect their airway, it is to prevent their lung infection, all those things. And actually, we are getting good results.
We are giving them a chance
to
survive.
Yes, because with time duration, once their disability is getting better, then we are removing them from ventilator.
Right.
And so
it's a life-saving procedure.
Exactly.
Yes.
This is a life-saving procedure, and in timely if we can intubate that patient, then definitely we can give him a fighting chance.
Yes.
Dr. Ghosh, I have a question. How do you go about the post this stroke sequelae basically?
So once, Dr. Lahiri, a patient of stroke is out of danger in terms of losing his or her life, and the patient is set for discharge, and even while the patient is recuperating in the hospital, the things that we must keep in mind is that stroke is a permanently disabling condition. Therefore, rehabilitation becomes of utmost importance in trying to limit or minimalize that disability. How do we go about doing it? Active physiotherapy of the limb which is weak or affected, balancing techniques, trying to help the patient balance better, trying to bring about an improvement in the quality of speech by speech therapy. And a lot of these patients with stroke have difficulty in swallowing, and there's a risk that the food particles that they are trying to swallow goes into the lungs and causes infection. One of the reasons why several times we have to intubate and place the patient under mechanical ventilation.
Aspiration
pneumonia, yes, which is a complication of stroke. So swallow therapy along with that. There are various aspects of rehabilitation. I'm not going to go into details, but rehabilitation is a very, very important aspect of follow-up stroke therapy. Very often, sometimes at least, not often, quite a few times, you will find that your patient has very stiff limbs post-stroke. If the damage has been quite severe, the limbs become stiff. Not only is the patient not able to move the limb, not only is the limb weak, but it becomes kind of contracted and stiff. So there's a lot of pain associated with it. Over the last 2 decades, various injections have been made available, botulinum toxin, which weakens the overactive muscles and reduces the pain and the stiffness of the limb, so that with active physiotherapy, you can try and regain some of the function. And in many cases, we find that with good physiotherapy, a lot of the function has been regained, which was previously lost because of stroke. So rehabilitation, physiotherapy, speech therapy, swallow therapy, etc. are extremely important components in post-hospital care.
So let me just summarize that this post-hospital care is very much important as the hospital care itself, because this care actually requires for not only for a small period of time, it's required for a longer time.
Yes.
So during those period it is required. So this is actually very important, because I have seen many patients, they don't continue that rehabilitation for long.
Absolutely. We need to emphasize to all those people who are listening to this particular program that stroke, discharge for post-stroke, discharge from the hospital is not the end of the story.
Exactly.
With that, we have given the patient a chance to live. That's all we have done. The next thing that we need to do is actively try and help our patient regain his or her lost functions, and that is to be achieved by rehabilitation. So it becomes a very, very important component of stroke workup and stroke treatment. And very often, family members neglect this important part of recovery, which I would like to emphasize must not be done. You must take good care of your family members, ensure that your patient is receiving wonderful physiotherapy, speech therapy, or whatever rehabilitation techniques are applicable in the patient.
So, in summary, just let me concise it. You identify any stroke symptoms. If you see, you bring the patient early to the emergency medicine department. If within the time frame, patient can be thrombolized, then post-thrombolysis, the proper appropriate treatment, and then post-treatment there is a time of your rehabilitation.
Yes, absolutely.
So all this part is essential to save life, to save limb, everything.
I couldn't agree with you more. Thank you very much. It was
Thank you.
Wonderful talking to you.
Yeah.